Welcome to today's 3M Health Information Systems webinar. My name is Jared and I will be your host. We'd first like to just start off by saying that we really appreciate your attendance today during this sensitive time in our country and across the world. In light of the circumstances, the majority of our team members are working from home today. So if you have any technical issues during this webinar, we apologize in advance and we'll work to get them sorted out as quickly as possible. In today's webinar, we will review coding and CDI staffing strategies to create flexibility during a pandemic and beyond. We encourage you to ask questions throughout the presentation. You can do this by using the questions feature in the web media controls, which is located in the lower right portion of your screen. We are recording today's presentation and a webinar archive will be available, so look out for an email from the next week that includes a link to the archive. A PDF that contains all the presentation slides is available for you to download, and that's located in the handout section of your web meeting controls. We will also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar. Today's presenters are Sue Bealey, Julie Tyson, and Michelle Bradley. Sue has more than 35 years of experience in the HIM field and acute care and spent most of her career managing coding and clinical documentation improvement teams. In her current role, she manages clinical content development and outsourced services for the consulting services business at 3M Health Information Systems. Julie has over 20 years of experience in the HIM field, predominantly in the acute care setting, managing all aspects of HIM. In her current role, she is a support manager for outsourced services at 3M Health Information Systems. Michelle previously served as senior coder and auditor for the University of Rochester's Level 1 Emergency Department. In her current role, she is a client manager for outsourced coding services at 3M Health Information Systems. I know we're all excited to get started, so Sue, I'll turn the time over to you.
Okay, thank you, Jared, and thank you to everyone joining us today for our presentation on coding and CDI strategies to create flexibility during a pandemic and beyond. Today, my colleagues and I will discuss the impact of COVID-19 and the resultant public health emergency on staffing for coding and CDI departments, as well as some important considerations to think about while trying to ensure that the important, valuable, and high-quality work both teams perform is maintained during the pandemic, recovery, and any peak and trough COVID-19 activities that may occur after this initial phase. We'll also talk about how outsourced coding and CDI staffing solutions may be an option for organizations as they grapple with all of this, and then we'll wrap up with a summary. Let's start by looking at a timeline for COVID-19 for some perspective. On December 31st, 2019, China informed the World Health Organization that 41 patients in the Wuhan province had contracted a mysterious pneumonia. Eventually, we learned that this pneumonia and many associated conditions are a result of SARS-CoV-2, a virus that caused COVID-19. On January 21st, the first coronavirus case is confirmed in Washington state. On January 30th, the World Health Organization declares a public health emergency of international concern. Less than a month later, on February 20th, the Centers for Disease Control and Prevention issue a supplement to the ICD-10-CM official guidelines for coding and reporting for coding of encounters related to the COVID-19 coronavirus outbreak. The release of a supplement to coding guidelines outside of the fiscal year updates on October 1st was big news. On February 29th, the U.S. confirms their first death as a result of COVID-19. We've learned now in the past few weeks that some deaths actually occurred prior to February 29th in California during early to mid-January. These have been linked to COVID-19 via postmortem exam. On March 18th, CMS recommends that hospitals limit non-essential care, including elective surgical procedures, and that they expand their surge capacity to treat COVID-19 patients. What also happened on March 18th is the Centers for Disease Control and Prevention's National Center for Health Statistics announces its intent to release an ICD-10 code for the 2019 novel coronavirus on April 1st. This was totally unprecedented and not in keeping with code set updates under HIPAA. A specific code for COVID-19 had been slated to be released on October 1st, 2020. However, due to the urgent need to capture the reporting of this data for surveillance and claims data, it was fast-tracked for release on April 1st. The next day, nearly all of our states declared a state of emergency. On April 1st, the U.S. implements the new and specific code for COVID-19, U07.1, in conjunction with updated coding guidelines regarding the use of the new code. On April 21st, the Centers for Disease Control and Prevention warned that a second wave of coronavirus in conjunction with seasonal flu could prove to be an even more difficult situation in the fall and winter of this coming year. This brings us up to today, where in the past week, we've seen many states begin opening up, including hospitals beginning to slowly ramp up elective diagnostic procedures and elective surgeries. The short and fast-paced series of events has impacted just about everything, not only in our personal lives and society in general, but as in medical settings where we perform and manage vital functions of assuring that clinical documentation and coding tell the patient's stories accurately, thoroughly, and completely. I'd like to spend a few minutes thinking about how the pandemic and recovery may impact CDI staffing and workload. We've been hearing from many colleagues that their clinical documentation improvement nurses have been moved to the front line to take care of patients during the surge in especially hard-hit areas of the country, which has resulted in understaffed or unstaffed CDI departments. We have heard of other instances where organizations have deemed CDI staffs as non-essential personnel and have furloughed some or all of the team, again resulting in understaffed or unstaffed CDI departments. For CDI departments that continue to operate, the surge of COVID-19 patients in hard-hit areas can result in a caseload greater than the existing CDI team can manage. This, coupled with the longer lengths of stay that COVID-19 patients experience, as well as the complexity of their disease process, results in lower productivity for the team. In addition, a CDI review of COVID-19 patients is not a typical CDI review. The CDI professional must search the record with a keen and investigative approach for every symptom, hint, or clue that's documented in the medical record and attempt to determine if it is related to this very sinister disease. It appears that the medical profession is learning of new manifestations of COVID-19 weekly. We have read about large vessel cerebral infarcts, COVID toes, and Kawasaki's disease in children, all within the past few weeks. CDI professionals need to be aware of the new understanding of this disease. Needless to say, this has a direct impact on their productivity. The amount of querying and clarification the CDI professional may need to do to connect all the dots between COVID and its manifestations, as well as present on admission status, has increased. The CDI professional is working harder to obtain query responses from physicians and providers who are in the throes of taking care of these critically ill patients. Let's just turn for a minute from the crisis mode that we're currently in to recovery mode. As hospitals begin to ramp up elective surgical procedures that have been on hold and patients with conditions that they have delayed seeking care for due to the pandemic return, the result might bring another surge in caseload that the CDI teams cannot completely manage. Throughout all of this, we must keep in mind that CDI professionals may experience not only professional challenges that COVID-19 has brought to them, but personal challenges as well, such as childcare issues or mental trauma, disorientation, or burnout that can impact CDI departmental staffing. I'd like to move on and talk about how the pandemic and recovery may impact staffing for coding. You're going to notice that this slide looks very similar to the one I just reviewed with regard to CDI staffing. For example, a surge of COVID-19 admissions or encounters in hard-hit areas may lead to a caseload greater than the current coding team can handle. This may range from an increase in coding of ancillary outpatient encounters for COVID-19 testing, long COVID-19 inpatient hospitalizations, to the exponential boom of professional telehealth visits. It is more than likely that coder productivity will just decrease as coders absorb the new codes and coding guidelines surrounding encounters for COVID-19 screening, diagnosis and manifestations, and deal with long and complex inpatient hospitalizations for COVID, and worry about accurately coding and applying new modifiers in the world of telehealth, just to name a few. Inpatient coders may need to pick up the slack, so to speak, for the understaffed or unstaffed CDI departments we talked about by issuing retrospective queries to physicians and providers and attempting to obtain responses to these queries. We can expect an increase in the amount of communication between coding professionals and their CDI colleagues as they work to ensure DRG reconciliation takes place with these very complex patients. The industry fully expects that coding rework related to COVID-19 will occur. One example of this is that it has been recommended that facilities and providers hold claims while COVID-19 testing results, while awaiting COVID-19 testing results. Another example is that CMS has issued some COVID-19 related advice that is retroactive, which means that claims resubmission will need to occur in certain situations. As I said on the previous slide, when hospitals begin to ramp up on elective surgical procedures and patients with conditions that have been delayed, they have delayed seeking care for due to the pandemic return, the result might bring another surge in caseload that coding professionals cannot manage and keep up with, that will result in backlog. And lastly, we need to recognize that coding professionals too may experience personal challenges related to the pandemic during, throughout, and or after the public health emergency has completed that can impact staffing. So moving on, we all know that the ultimate goal of CDI and coding professionals is to produce a well-documented and well-coded patient medical record every single time. I would like to make the argument that these goals are especially more important than ever for the COVID patient's medical record for the following reasons. First, we need to tell the story of COVID-19 patients. What manifestation or manifestations of COVID-19 did they experience? How sick were they? What was their risk of dying? What was their outcome? Did they live? Did they die? Did they test positive or test negative? Second, and extremely important, is the need to support research and public health and planning initiatives with accurate, thorough, and complete coded data. Prior to this pandemic, we might have not thought about this byproduct of coding. Now we are all hyper alert and want to make certain researchers have all information possible about manifestations and outcomes in order to determine efficacy of treatment and risk factors. We want to make sure public health officials can use coded data to not only plan for and implement initiatives for the near term, but for future disease outbreaks as well. And we want to make sure that this information can be shared on the world health stage. Third, we want our hospitals, as well as local, state, and federal officials, to understand how many ventilators, ECMO equipment, and dialysis machines were needed and may be needed in the future. We want our providers to know the ratio of in-person to telehealth visits that were delivered during this public health emergency in order to chart a course forward for future delivery of health care. All of this is dependent on accurate, thorough, and coded data. Fourth, Quality coded data will ensure accurate payment today and determine future payment decisions, as well as hopefully avoiding denials. You might ask, why am I talking about data and integrity during a presentation about staffing? The reason for this is because during public health emergencies, when our facilities and providers are experiencing tremendous financial loss, the revenue cycle is hurting, and there is extreme pressure to code as quickly as possible without the right staffing complement, we need to advocate for taking the right amount of time to capture and report this critical information. I would also argue that we need to increase the amount of auditing, either on a pre-bill or retrospective basis, to validate what has been documented and coded to ensure accuracy. Changing the subject a bit, I wanted to talk about claims processing. For areas hard hit by COVID-19, the volume of claims submitted by facilities and providers are likely to increase during the surge. We know that the processing and submitting of these claims will be more complex and resource intensive for facilities and providers. I've been listening in on CMS's office hour sessions that they've been holding at the end of the day on Tuesdays and Thursdays for the past 4 weeks. We're just moving into the 5th week this week. During these sessions, participants can ask questions of a panel of CMS officials about the processing of COVID-19 related claims. The audience has asked many questions regarding waiver status, the application of modifiers, telehealth visits, testing, and payments, to name a few of the consistent topics. CMS continues to update their frequently asked questions and has been issuing new and updated guidance. CMS has stated on these calls that claims rework and rebilling will need to occur in certain instances, especially when new guidance is issued and it is made retroactive. That means if the claim has already been submitted, it will need to be resubmitted, reworked and resubmitted. I mentioned claims processing in this presentation on staffing because it behooves organizations to avoid coding backlogs in order to allow time for claims to be worked and submitted as quickly as possible during this difficult time. We know that our billing colleagues in our various facilities are going to spend extra time trying to get as clean as possible claims out the door. I'm going to hand this presentation over to my colleague, Julie. Julie?
Thanks, Sue. So Sue has presented various scenarios and impacts on many of the different revenue cycle workflows that we have seen through our current customers or heard about during the past few months of this pandemic. With this slide here, we want to specifically focus on some questions you need to ask yourself in regard to staffing considerations as you navigate your current situations and start planning for the future, whether it be back to normal or setting up a contingency plan for the possible second wave of COVID-19. So when you think about current staffing, your current staffing model and planning for recovery, please take some of these items into consideration when reevaluating your needs for staffing. First, we want to address staffing challenges and schedule flexibility. So depending on your situation, you may be faced with overwhelmed staff due to the increased volume of work, or it could be you are evaluating how to best phase your team back in once volumes increase again. So you want to start to plan and take into consideration that some of your coders or CDI, if they previously worked on site, they may not be able to come back immediately, or they may have a need for a more flexible schedule due to childcare options not being available or certain other circumstances. So do you have a plan in place to cover the volumes if these situations occur? Next, discussing backlogs and scalability. Do you currently have a growing backlog due to the surge of COVID-19 patients coming in? Did your facility react quickly and add new services such as telehealth visits, which may cause, this to be a new work type for your coders to code? You want to think about this in your current staffing model. Can you accommodate these additional volumes, or do you have a backlog, or do you have a backup plan in place to cover this now and potentially for ongoing telehealth visits in the future, or the second wave of new patients coming in as well? Next, productivity. So Sue mentioned that for coding and CDI, there may be a productivity lag due to longer lengths of stays and the complexity of these cases due to COVID-19. Have you reevaluated your productivity for your staff and how this is currently impacting them? And then the potential for this to be your new normal as it relates to staffing needs and what staffing complements you need going on in the future. From an educational standpoint, over the past few months, there has been a flood of information presented to the coding and CDI teams related to the accurate assignment of codes for COVID-19. Managing these continuous updates is certainly challenging, and it can uncover educational opportunities that you may not know existed in other areas as well. These additional guidelines and documentation challenges have certainly played a role in slowing down coders. And have you identified within your team the experts or the educators that can help you with this additional education and follow up on these cases that need to be reviewed? And of course, that leads into quality and compliance. Do you have a program in place to ensure that documentation and coding is accurate? Have you updated your policies and procedures to reflect the updates for COVID-19 guidelines and the timelines that apply for when the new codes need to be applied? Certainly this pandemic has highlighted the importance of auditing and checks and balances, and how, you need to think about how you will maneuver this going forward from a compliance standpoint. And lastly, claims processing. As Sue stated earlier, for areas that have a surge of patients, claims processing has become more complex for these cases, therefore creating backlogs, denials, and potential more rework. These additional volumes are impacted even greater by coding backlogs and working of edit delays. Do you know how you are going to address this from a coding perspective, so to enable faster overall accurate claims processing, getting the bill out correct the first time to reduce the rework on the back end, ultimately creating a healthier financial state for your facility? So overall, we have listed here many items to consider when reevaluating your staffing strategies. I know that we have always stressed in the healthcare facility to create disaster plans or anticipate what might go wrong. I don't know if we could have anticipated this happening, but I do believe this pandemic has emphasized to us the importance of having staffing plans and having options that we may not have anticipated in the past. So to help you maneuver your specific situation, one consideration could be having a backup plan for supplemental services that 3M has to offer. So in the next few slides, Michelle will share some of those available options to you.
Thank you, Julie. So as many of the states begin the process of reopening and organizations start seeing patients and performing elective surgeries, coding operations are going to need to be able to scale up to meet the high demand. Our 3M outsourced coding teams are prepared and ready to absorb any coding and CDI assistance to help maintain productivity and keep your organization on track. Our outsourced services include a dedicated account manager, as well as a specialized coding and CDI team. You will have one point of contact for all your questions and needs. We offer many different types of coverage based on your organization's needs. We can customize your coverage to include being a permanent coding solution and CDI solution, backlog coverage to help your organization get caught up. We are available to help for short-term staffing, as well as being a great solution to have a team on standby should the need arise. Our team is proficient in all professional and facility coding specialties, and our coders are 100% certified through the AAPC and AHIMA. Regarding quality, our team undergoes rigorous quality assurance by our quality team. We also provide our team with ongoing education and on any regulatory and coding updates. Just to recap the services we offer CDI support, outsourced coding, educational services, and auditing. And we are operating at full capacity and can implement your organization quickly and efficiently. I'm going to turn this back over to Sue to do a summary of everything we discussed today.
Okay, thank you, Michelle. Well, I hope my colleagues and I have given you some food for thought as you may be looking at staffing for the pandemic, recovery, and potential resurgence. In summary, outsourced coding and CDI support can help hospitals and providers under siege to maintain their critical CDI and coding programs, keep control of their days not final billed, support timely claims filing and payment, ensure correct reimbursement, and provide the most accurate coded data set possible for each patient receiving COVID-19 related care and treatment. Outsourced support will also help customers during the recovery phase when hospital censuses and outpatient surgery volumes may ramp higher than normal, and as well as when elective surgery, inpatient surgeries ramp up again as well. Diagnostic procedure volumes may be higher than normal when these are able to be scheduled, and physician visits in clinics or offices may be higher than normal when patients are able to return or more telehealth visits are scheduled. Thank you for your time today. We wish you well during the continuation of this public health emergency and beyond. I'd like to turn this back to Jared. Jared?
Perfect. Yes, and let's go ahead and advance the next slide. There we go. Okay. So yeah, let's move into the Q&A portion of the webinar. If you'd like to submit a question, you can use the questions feature in your web meeting controls. That's located in the lower right corner of your screen. While we're waiting for a few questions to come in, I'm going to launch a poll here where you can select your top interest to learn more about. So give that a few minutes. And while those are coming in, as a reminder, we recorded today's presentation and a webinar archive will be available. So look out for an email from the next week that includes a link to the archive. A PDF that contains all of the presentation slides is available for you to download, and that's located in the handout section of your web meeting controls. Lastly, we are providing a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar within the next few hours. Okay, I'm just going to give that poll just a few more seconds. Okay, closing out. Okay, so let's jump right into the Q&A here. First question. Is your outsourced coding team educated and prepared to code in the new COVID-19 environment?
Jared, I'll take that question. Yes, absolutely. Our team is educated and updated with all telehealth, COVID diagnosis-related issues, updates. We periodically provide education to the coding team, but with all the updates, we're doing it daily.
Perfect. Okay. Next question that came in. Do you offer both offshore and domestic-based coding support?
Jared, I'll take this one too. Yes, we do. We offer both domestic and offshore based on your needs. The account management and services remain the same no matter if you choose domestic or offshore.
Okay, perfect. Thank you. Another question here. Do you offer remote CDI staffing support?
Hey, yes, this is Julie, so I can take that one. So yes, we do offer remote CDI staffing support. We also offer remote coding and on-site CDI support as well. We do try to offer the services that's best to meet the customer's needs. So currently in the situation that is going on now with the pandemic, remote services seem to be on high demand, and we do offer that, and we utilize the same processes that any remote person that the client has internally to get into the system. That's what our staff will do as well. So we'll follow the same processes from a remote standpoint that the internal team uses at your facility. Thank you.
Perfect. Thank you. We do have a few more questions, but we will plan to follow up via email with any questions that we didn't answer here today. Sue, Julie, Michelle, thank you for this excellent presentation, and thank all of you for joining us. This concludes today's 3M Health Information Systems webinar.